Upon discovering a patient who is unresponsive, make sure the area is safe to approach, wearing the appropriate PPE. Gentle stimulus, shake and shout, and pull the emergency buzzer. Once the emergency buzzer has been pulled, assess the patient. Begin by performing a head tilt chin lift maneuver to open the airway. Once additional assistance arrives, ask them to dial 2222 if you work at Conquest or Eastbourne. If you work in the community, dial 999 and ask for an ambulance. Once emergency help has been requested, begin chest compressions. For adults, the rate is 100 to 120 beats per minute, the depth is 5 to 6 centimeters, and the ratio should be 30 compressions to 2 ventilations. With emergency equipment arriving, attach the bag valve mask to oxygen. The oxygen should be turned on at a rate of 15 litres per minute and connected to the bag valve mask. With the bag valve mask attached to oxygen, it becomes a two-person technique. One person maintains the airway, the other person performs chest compressions and squeezes the bag at a ratio of 30 to 2. When you squeeze the bag, you should see the chest rise and fall. If additional support arrives, then rotate chest compressors when you get tired or at 2-minute intervals. If the patient is on a bed, trolley or couch, leave them on the bed, trolley or couch. If the patient is discovered on the floor, leave them on the floor and begin resus with them on the floor. Do not attempt to move them unless it is dangerous for you to resuscitate them in that particular area. Continue resuscitation until help arrives, you become exhausted, or the patient shows signs of life. And by that we mean purposeful movement, so eye opening, coughing, moving limbs, etc. At Conquest and Eastbourne DGH, we have a mechanical CPR device called Lucas. Lucas is brought to all cardiac arrests at Conquest and Eastbourne DGH by the porters 24/7, as well as having it in certain critical care areas such as ED. To use the Lucas device, initially turn it on. It will then perform a self-test. The orange button is illuminated, and the orange button allows you to move the plunger up and down. To attach Lucas, it requires 4 people. Person 1 will move the arms up and out of the way. Person 2 will roll the patient. Person 3 inserts the backboard, and person 4 will clip the device onto the backboard. Once the device is connected to the backboard, with the orange button illuminated, you can then move the plunger down onto the patient's chest and begin play at a ratio of 30 to 2. In 30 to 2 mode, once the device gets to 28, the green light will flash and then it will make 2 small beeps. This indicates that you're approaching 30 to 2, and then the machine will pause to allow you to give 2 breaths. After the 2 breaths have been delivered, the machine will then kick in again at a ratio of 30 to 2. To pause the machine, push the pause button, and if you need to move the device, then again push the orange button so that you can move the plunger so you can readjust the device or take the device off of the patient. Pediatric resuscitation is different to adults in terms of the ratios, but also the etiology in how they have a cardiac arrest. Children tend to have a hypoxic event, which leads on to a secondary cardiac arrest, not a primary event, such as in adults. Make sure the area is safe to approach with the appropriate PPE, and then assess the child. When assessing the child, it's gentle stimulus, and we do not ever shake babies. Having assessed the child and the child is unresponsive, again call for help, pull emergency buzzers, etc. And then open the airway with the head tilt chin lift maneuver, but keeping the head in a just past neutral position, not hyperextension. Once you've made an assessment for no more than 10 seconds and you believe the child is not breathing normally, again attach the pediatric bag valve mask to oxygen at 15 litres per minute and begin initially with 5 breaths. The 5 breaths having been delivered, will then assess the child, and if there's no obvious signs of life, i.e. colour change, etc., then begin chest compressions. Chest compressions in infants have changed with the G2025 guidelines, so we now perform CPR on infants with the thumbs technique. The thumbs are still on the lower half of the sternum. Overlap your thumbs and compress the chest in an infant 4 centimeters, but it must be at least 1/3 of the depth of the child's chest. The rate is the same as adults, 100 to 120 beats per minute. For older children, obviously thumb CPR won't work, so you can now use one-handed CPR. The position on the chest is the same as for adults, so the lower half of the chest, and the depth of compression is now 5 centimeters, but again it should be at least 1/3 of the depth of the chest. The ratio remains the same at 15 to 2, but initially with 5 initial breaths. For infants that are choking, first of all establish that the child is conscious and that they have an ineffective cough. If they do have an ineffective cough, we need to intervene. So initially we will support the child's head by hanging onto the mandible and ideally get them in a head down position. Using the heel of one hand, deliver 5 back blows between the scapula. In between each back blow, check to see if anything has come out. After you've delivered 5 back blows, if this has had no response, then we'll turn the child over onto their back, and now we will begin chest thrusts, but using the technique akin to CPR, so that will be thumbs. Ideally they will be in a head down position, but depending upon the rescuer and the size of the child, that may not be possible. But overlapping your thumbs, perform chest thrusts, which are very similar to chest compressions, but the rate can be slightly slower. And rotate between back blows and chest thrusts until the object comes out, help comes, or the child becomes unresponsive. After they become unresponsive, then begin CPR as per normal. For bigger children and adults who choke, we would encourage them to cough, and then we would deliver 5 back blows between the scapula. If those 5 back blows are ineffective, then we would get behind the patient. We would make a fist with one hand, cup the hand around the fist, and then pull inwards and upwards in a J-shape maneuver. After those 5 abdominal thrusts, if they're not effective, we go back and we deliver 5 back blows. And we rotate between 5 back blows and 5 abdominal thrusts until help comes, the object comes out, or the patient collapses. Once patient collapses from choking, then we begin resus in the normal guise. Initial step, determine if they're responsive. If they are, then perform an A to E assessment. If they're unresponsive, call for help via 2222 or 999 if you work in the community, and pull the emergency buzzer as per normal. You then need to determine whether or not they're breathing. If they are breathing, again perform an A to E assessment. If they're not breathing, the initial step is to pass a suction catheter down the tracheostomy tube. Having passed the suction catheter, if they're not breathing, then we need to connect the bag valve mask device to the trachea tube. Again connected to a high flow oxygen at 15 litres per minute. Remove the mask and attach the bag to the trachea tube. If the chest rises, then continue to ventilate until help arrives. If it does not rise, then you will need to remove the tube. If the patient has a cuffed tube, deflate the cuff, undo the ties and remove the tracheostomy tube. Having removed the tracheostomy tube, either ventilate via the stoma or the mouth. If you're ventilating via the mouth, you will need to occlude the stoma. Adrenaline auto-injectors in the United Kingdom come in two types, EpiPen and Jext. Within ESHT, our preferred AAI is Jext. However, on occasions, you may get EpiPen as well. To use Jext, remove it from the box and it will come in a plastic case. Once you've removed it from the plastic case, there's a yellow cap at one end and a black tip at the other end. To inject, you can inject through clothing, make sure there are no phones, keys, etc. From a landmarking perspective, it's between the hip and the knee on the outer aspect of the thigh. You can hold the AAI in whatever hand you like. We would recommend that you put the other hand on the inside of the patient's leg to give you something to push against. Once you inject into the leg, for Jext, you hold in position for 10 seconds. After 10 seconds, remove the device and a needle guard will come down. For EpiPen, EpiPen comes in a different coloured box. Remove the device from the box and once again it will be in a plastic case. Remove it from the plastic case and you will see a blue cap at one end and an orange tip at the other end. Remove the blue cap and from a landmarking perspective it's in the same position as before, and when you push the device into the leg, this time it will only be for 3 seconds. If you do everything for 10 seconds, it will be absolutely fine.